Hello everyone. In this video tutorial, we'll be talking about high flow nasal oxygen therapy. So high flow nasal oxygen therapy has gained a lot of importance, especially during this COVID era. So in this tutorial, we'll discuss about the physiology, mechanism of action, the pros and cons, as well as other miscellaneous aspects of high flow nasal oxygen therapy. So oxygen therapy devices, we can broadly classify them into low flow devices and high flow devices. Low flow devices are those devices which utilize low flows of oxygen, that is like ranging from 1 to maximum of 15 to 20 liters per minute. And the examples would be the common nasal cannula and the oxygen mask which we use. And this oxygen mask can be with unidirectional valves or with a non-rebreathing valve or with an oxygen reservoir bag, etc. But whatever it is, these are low flow devices because they utilize oxygen from the flow meter at rates of 1 to 15 or 20 liters per minute. And these are also variable oxygen therapy devices because these devices can deliver only variable FiO2. That is, the FiO2 that is delivered to the patient is only predictable. You cannot pinpoint exactly and tell that, yes, this is exactly the FiO2 that the patient is receiving, because the amount of oxygen that reaches the alveoli will depend on the dead space of the device as well as the dead space in the patient, as well as the respiratory rate or the minute ventilation of the patient himself and the clinical condition as well. So the other kind of devices are high flow devices, and the examples would be non-invasive ventilation, where we use a tight fitting face mask and connect to a mechanical ventilator. And then the usual invasive mechanical ventilator, where the patient is intubated and mechanically ventilated. So in these high flow devices, rates as high as up to 200 liters per minute are used. So if you check the flows in a ventilator, you can always see that it flows from 60 liters per minute to a maximum of 200 liters per minute in most of the ventilators. So high flow oxygen therapy device, the one which is seen in this picture, is actually a device which can be classified as a high flow oxygen delivery device. And also most of these high flow delivery devices are also fixed performance devices, in contrary to the low flow devices which are variable performance device. In fixed performance device, if you set a particular FiO2, most of the time or 99% of the times the patient receives that particular exactly fixed FiO2. So if you have a look at the flows that I use in high flow machine, it usually ranges from 20 to 60 liters per minute. So the low flow devices or the conventional oxygen therapy devices use flows up to maximum of 20 liters per minute. High flow oxygen, nasal oxygen device uses 20 to 60 liters per minute. And then beyond that, mechanical ventilators, whether invasive or non-invasive, they use flows as high as 60 to 200 liters per minute. So in this talk, we'll be talking about the physiology, the mechanism of action, the indications and contraindications, evidence update, comparison of high flow device with conventional oxygen therapy and non-invasive ventilation, and also I'll share my ICU experience with high flow nasal oxygen therapy. So the traditional nasal cannula, which is a low flow device, uses a maximum flow of 4 to 6 liters per minute, and it delivers a variable FiO2 of 37 to 45%. The disadvantage is that it delivers cold and dry oxygen, which can result in nasal mucosal irritation, crusting, and bleeding. And also there can be high levels of leakage of air around the oxygen source, which can even dilute the oxygen that you're delivering further. So the same thing can happen with oxygen mask as well. So these are considered as conventional oxygen therapy devices. These low flow variable performance devices are considered as part of conventional oxygen therapy, where the maximum flow rate will be 15 to 20 liters per minute. So why is this flow important? One thing you need to understand is that when a patient is in respiratory failure, he'll be using very high flows. His body will be trying to get in more oxygen by utilizing all the muscles, but thereby increasing the respiratory rate. And sometimes the tidal volume will be low, or sometimes the tidal volume will be high, but the respiratory rate will go up, and this can result in increased inspiratory flow. So the increased inspiratory flow in patients with respiratory failure can go as high as 30 to 60 liters per minute. So if you have to ensure a stable FiO2 delivery to these kind of patients, if you have to ensure the delivery of FiO2 to the alveoli, then whatever device you attach to the patient should meet or exceed this particular patient's inspiratory flow, so that the room air entrainment is reduced. So if you have a patient with respiratory failure breathing at 50 liters per minute of inspiratory flow, and if you keep a nasal prong or cannula at a rate of 4 liters per minute, there is a lot of dilution which is happening, and the patient doesn't get good FiO2 levels. So that is where the conventional oxygen therapy fails. There is limited efficacy of conventional oxygen therapy in patients with respiratory failure, because the maximum flows that you can give would be 15 or sometimes 20 liters per minute, which can account to maximum of 75% of FiO2, max to max. That too, it's when you use an oxygen mask with non-rebreathing valves and a reservoir bag, etc. So when you use high flow nasal oxygen therapy, it delivers 100% humidified and heated oxygen. That's the beauty of high flow nasal oxygen therapy. And also there is a precise titration of FiO2. The flow rates that can be used in high flow nasal oxygen therapy are 20 to 60 liters per minute. So this is an innovative and effective modality which can be used in the treatment of early respiratory failure. I repeat the word early respiratory failure. It is difficult or risky to use it in cases of severe respiratory failure. We'll discuss that later. So it can be used in respiratory support for critically ill patients, this particular therapy. So the components of high flow nasal oxygen therapy device would be a flow meter, which comes inbuilt with the machine, and there'll be an air oxygen blender, and that particular area, that particular part will have a housing which has to go to your central oxygen supply port. And from there, there'll be four corrugated tubings which will go into the humidifier. And from there will be a heated inspiratory circuit which is inside the circuit. From there, the oxygen will go via a wide bore nasal cannula to the patient. So these are the components of a high flow nasal oxygen device. So this is the picture. Another photo is the flow meter. This is the corrugated tubing going into the high flow nasal oxygen device, where you can see the active humidifier there. Then you have the corrugated tubing again, which is like an expiratory port, and then it goes into in the inspiratory port, and from there it goes into a wide bore nasal cannula which is attached into the nostrils of the patient via a harness. So what's the mechanism of action of high flow nasal oxygen? Since oxygen is delivered at very high flows, a lot of pressure increases the nasopharyngeal diameter, so thereby decreases the airway resistance. And also the nasopharynx is a potential space, so when you have high flows of oxygen delivered there, it expands a little bit and it forms an oxygen reservoir. It acts as an oxygen reservoir there. It also increases airway pressure and gives a slight PEEP effect to the patient. And also, because of very high flows delivered, it helps you for carbon dioxide washout also. So these are the mechanisms of action. So it increases the nasopharyngeal diameter, thereby acting as an oxygen reservoir. Also, it decreases airway resistance. Then it increases airway pressure and causes a PEEP, and also washes out carbon dioxide. So the physiological effects include a reduction in nasopharyngeal resistance to inspiration, since there is a decreased anatomic dead space owing to washout of upper airway carbon dioxide. There is a PEEP which is exerted, which will increase the FRC as well as the alveolar recruitment. And a constant FiO2. In the high flow nasal oxygen device, you have an option of fixing what is the FiO2 you need to give to the patient so that the air oxygen blender will blend that and give to the patient. And since those are thick or widebore nasal cannulae, it will fix exactly into the anterior nares of the patient, thereby reducing room air entrainment. So constant FiO2 is delivered to the patient, thereby improving oxygenation. So this can result in decreased metabolic cost and work of breathing as well as reduced carbon dioxide generation because of the same. Also, preconditioning of the inspired gases, that is, we're delivering warm as well as humidified oxygen. So this can improve tolerance also in the patient. So because of the humidified oxygen that is delivered, there'll be a better secretion clearance and superior comfort, and also lesser chance of atelectasis because it's not the cold, dry oxygen which is going into the patient. So the indications of high flow nasal oxygen therapy would include acute hypoxemic respiratory failure, especially in the early stages. Then we can use it in acute exacerbation of chronic obstructive pulmonary disease, acute hypoxemic respiratory failure in immunosuppressed patients, because in immunosuppressed patients, if you intubate them, then there is more chance of ventilator associated pneumonia. So in such patients, this is a very good alternative. You can use it in patients with respiratory failure who are for palliative care and who have a do not intubate order. It can also be used in patients post-surgery, post-extubation. So in these patients, you can prevent re-intubations, especially in high-risk patients who have a higher chance of getting re-intubated. And also it can be used for the prevention of post-operative respiratory failure, especially in cases of thoracic and abdominal surgeries and also in obese patients. So this high flow nasal oxygen therapy can also be used for pre-oxygenation and apneic oxygenation of high-risk patients. If you have a patient whom you have predicted a difficult airway, in such patients also, HFNO is of great use. It can be also used to supply oxygen to a patient during bronchoscopy. And also it has been found to be useful in patients with sleep apnea as well as in acute heart failure. So these are the various indications of high flow nasal oxygen therapy. So in immunocompromised patients, it has been found that high flow nasal oxygen use has been associated with lower 28-day mortality compared to patients with standard oxygen or conventional oxygen therapy and NIV. It also reduces intubations and mortality when compared to NIV if used as first-line therapy. In patients with do not intubate status and respiratory failure, such as pulmonary fibrosis, pneumonia, COPD, cancer, advanced malignancy or hematological malignancy, advanced congestive heart failure, etc., this modality of oxygen therapy can be used. In post-operative patients, HFNO has been found to have significantly reduced the re-intubation rate and also rate of escalation of respiratory support compared to conventional oxygen therapy. And this has been found in adult surgical patients who have been extubated. But there has been no difference in the incidence of postoperative pulmonary complications or mortality as per some studies. And coming to prevention of reintubation is one factor which increases ICU stay and hospital length of stay as well as morbidities and mortalities. So when you use high flow nasal oxygen therapy, it reduces the need for NIV and reintubation. You can use it preemptively also. Like if you use preemptively in selected cases, you can see that there is better PaO2 by FiO2 ratios in these patients, lesser desaturation episodes, less interface displacement. Most of the time, a disadvantage with NIV that you see is that most of the patients are claustrophobic, and also they find a tight fitting mask over the face very uncomfortable. And when you have to remove it while you are feeding the patient or while giving some oral medications. So sometimes Ryle's tube also comes in the way and causes leaks. So these problems are solved with high flow nasal oxygen therapy. There's less interface displacement. You have fewer reintubations if you use it preemptively, and it's been found to have a lesser requirement of ventilatory support. The benefits of high flow nasal oxygen are greatest with early application of the device. It's better tolerated than non-invasive ventilation, and it also reduces the need of escalation of respiratory support. But one problem is that there are no valid predictors of treatment failure in high flow nasal oxygen therapy. There are no predictors like any valuable scores or anything which will tell you that, okay, this particular patient is going to fail HFNO therapy. So this can result in unnecessary delay in intubation beyond 48 hours. All that you have to look for in such patients are signs of any progressive respiratory failure while on high flow nasal oxygen therapy. Because if you intubate a patient very late, so that itself can result in prolonged mechanical ventilation and increased mortality. So hence, when you put a patient on high flow nasal oxygen therapy, the most important things to be considered are clinical judgment, and you should have set defined intubation criteria. Intubation criteria any ICU will already have. So you have to stick to those criteria and use your clinical judgment, and then go for intubation when you have put a patient on high flow nasal oxygen therapy. So there is an index by name, ROX index, which is respiratory rate to oxygenation index. It's the ratio of SpO2 to FiO2 to respiratory rate. So ROX, you have to, that is, let me explain to SpO2 by FiO2 is the value that you obtain that should be divided by the respiratory rate to get the ROX index. If the ROX index is greater than 4.88 after 12 hours of high flow nasal oxygen therapy, they say that the patient is unlikely to need mechanical ventilation. But the disadvantages are that it's unclear if this index can be applied to patients with respiratory failure due to causes other than pneumonia, because this ROX index has been extensively studied in patients only with pneumonia. And it also cannot be used to predict outcomes at time points before 12 hours. So we cannot use it to identify those patients in whom high flow nasal oxygen therapy will fail. What we follow in my ICU is that after 2 to 4 hours of high flow nasal oxygen therapy, we repeat the ABG and we look for the acid-base status as well as the PF ratio, PaO2 by FiO2 ratio. If that is showing improvement, then we consider it as a success. Rather than saying success, I would say there are very less chance of the patient clinically deteriorating. Of course, it's not just by going with the ABG, we also go via clinical judgment as well. We also look into the vitals of the patient as well as the entire clinical condition of the patient. So there has been no scoring threshold which can reliably predict which patients among high flow nasal oxygen would require intubation. So a close monitoring of the patients who are receiving this therapy is the key. And well-defined intubation criteria should be there to avoid delayed extubation. For example, persistently high respiratory rates despite high flow nasal oxygen therapy. Beauty of high flow nasal oxygen therapy is that the respiratory rate immediately comes down. In early respiratory failure, the patients will be breathing at 40 to 60 respiratory rate per minute, RR per minute. So moment you fit the high flow nasal cannula, you can see that within a duration of 5 to 10 minutes, the respiratory rate of the patient decreases. So when you put a patient on high flow nasal oxygen therapy, it is not just the saturation that you have to look at. You have to also look at the respiratory rate, whether that is coming down. So that will be a good sign. So that shows that you are providing enough flow to the patient and the patient's work of breathing is reducing. So other criteria for intubation would be ongoing hypoxemia or worsening respiratory failure, ongoing hemodynamic instability, thoraco-abdominal asynchrony, presence of non-pulmonary organ failure, and declining mental status. So the potential deleterious effects of high flow nasal oxygen therapy would be unnecessary and potentially precarious delays in intubation, greater expense of care relative to low flow nasal cannula, because this particular cannula has to be taken care of and the machine is also pricey, increased complexity and training to initiate care, decreased mobility because of this machine and the huge circuit and the wide bore nasal cannula, and risk of ineffective sealing of the passageways leading to air leak and loss of PEEP. Like the most common thing which happens is patient has a huge nasal cannula in his nares, and most of the time they have a tendency to open their mouth and breathe, which sometimes takes away the PEEP effect. Though they say that it's not very significant, most of the studies done recently have shown that there is no much decrease in the PEEP effect. But then if the nasal cannula, the wide bore nasal cannula doesn't fit properly into the nares because the anatomy of the patients vary, then it can result in air leak. And also there's a potential to inappropriately delay end of life decisions, because you have put the patient on high flow nasal oxygen therapy in case of patients with do not intubate orders. Sometimes that results in unnecessary delay and prolonging a poor quality of life. So the contraindications for high flow nasal oxygen therapy would be respiratory arrest, post CPR, worsening hemodynamic instability, altered consciousness when you have a risk of aspiration. So I would like to say that you can use high flow nasal oxygen therapy in patients where NIV is contraindicated. Suppose the patient has had a recent esophageal or gastric surgery. Then in such cases, post-operatively, instead of using an NIV device in cases of mild hypoxemia, you can go for a high flow nasal oxygen therapy device. So about my ICU experience is that in the medical ICU, we have found HFNO to be really helpful in cases of early hypoxemic and hypercapnic respiratory failure. In patients with COPD, you can give high flows of gases in the sense air oxygen mixture without increasing the FiO2. You can give even 21% oxygen using a high flow nasal oxygen device at high flows so that the carbon dioxide washout occurs. Otherwise, in a COPD patient, if you put a patient on a non-rebreathing mask with reservoir bag, if you increase the flows to 20 liters, 15 to 20 liters per minute, you're also increasing the FiO2. And in most COPD patients, the hypoxic drive is taken off, and sometimes it results in carbon dioxide retention and worsening type 2 respiratory failure. So in such patients, this is a very good device. We use it in palliative care because my ICU takes care of cancer patients. So in palliative patients, we do not have to trouble them by intubation or non-invasive ventilation. So if they present with a short period of respiratory distress, then we try helping them out using high flow nasal oxygen devices. And it's also sometimes used in patients with do not attempt resuscitation orders. In surgical ICU, it's been found to be really helpful, especially in patients who have undergone thoracic and abdominal surgeries when there has been some thoracotomy done or lung resections done or even diaphragm resections in many extensive cancer surgeries, where you can improve the PF ratio to about 300 to 400. When the PF ratio drops to less than 400 or 300, we initiate these patients preemptively on high flow nasal oxygen therapy. And also in high-risk patients like obesity, patients with a history of heart failure, etc., or even COPD patients, in post-extubated phase, immediately we start the patient on high flow nasal oxygen therapy. And this has been found to reduce, we have observed that this has reduced the rate of reintubation as well as use of NIV. So hence, we have lesser reintubations or readmissions as well as lesser length of ICU stay and hospital stay. Also, that means there is a lesser escalation of respiratory support to NIV or invasive ventilation. So that is all about high flow nasal oxygen therapy devices. Thank you very much for your patient listening.